The Way Opens. Enlightenment of a Social Drinker. Chapter 9. Over 22 years ago, the broken cord provided an epiphany that prenatal alcohol exposure causes brain damage in children, even before a woman may know she is pregnant. This light bulb moment sparked a fire to promote awareness and treatment of ND-PAE. In the early 1990s, as a 20-something, I found my calling for prevention and treatment of the condition known as neurodevelopmental disorder associated with prenatal alcohol exposure. This journey began as I was working full-time in clinical neuroscience research for Burroughs Wellcome Company, the maverick pharmaceutical company in Research Triangle Park, North Carolina, known for bringing the first AIDS drug to the market, AZT or zidovudine, also known as Retrovir. The orphan drug had shot up the FDA's approval pipeline rapidly in order to treat more patients with advanced disease. To say the least, it was an exciting time and stimulating time to be a young research assistant in such an innovative company. Just a year after BW co-researchers Drs. Gertrude Elion and George Hitchings won the Nobel Prize in Physiology and Medicine for their discoveries leading to the development of AZT. Over the span of a total of roughly 4.5 years with the company, I saw drug development from laboratory science through the process of preclinical trials to the developing and monitoring clinical trials for the Food and Drug Administration approval. Cocooned in that unorthodox, quasi-academic think tank environment, my path unfolded. The first in my family to attend college, I charted a course beyond my father's expectation for me to go to vocational school and become a secretary. Navigating upstream to a career in science, I eventually graduated magna cum laude from North Carolina State University with a degree in microbiology, landing a job in drug development in Research Triangle Park with Burroughs Wellcome Company. After 2 years in preclinical research, I left bench science to work on clinical trials. For the next 2 years, I enjoyed traveling to major cities, experiencing the food, culture, and nightlife while monitoring pharmaceutical studies. In hindsight, the combination of unique personal perspectives, a working-class upbringing, my love of science, a social drinker's mentality, and a maverick spirit that I could make a difference prepared me for my awakening. On one of my weekly trips to New York's Cornell Medical Center, I met a young researcher who opened my eyes to an appalling public health catastrophe, now understood as neurodevelopmental disorder associated with prenatal alcohol exposure, ND-PAE. He described how this non-contagious yet preventable epidemic had destroyed the culture and diminished the intellectual capacity of indigenous communities worldwide, and had silently spread to middle-class American neighborhoods. Both appalled and pathetically ignorant, I felt ambivalent listening as he described his research in pregnant rats dosed with varying amounts of alcohol at intervals during pregnancy, mimicking social drinking versus binge episodes and chronic alcoholism. As a microbiology major, I could appreciate the differences between the nerve endings in exposed rats and those of normal, healthy, unexposed control animals. Nerve cells taken from rats born to mothers with any degree of exposure showed damage to the neural end plate or nerve ending next to the muscle cells. Even at minimal doses, the nerve endings of the prenatal alcohol-exposed pups were grossly affected, shriveled and disfigured, much like gnarly fingers afflicted with rheumatoid arthritis. In contrast, the unexposed nerve cells had more delicate, intricate finger-like projections to the muscle cell. His research provided evidence for prenatal alcohol-induced nerve damage associated with sensory and fine motor issues related to sensory integration disorder. As we discussed his findings, I was hardly moved by the results. After all, as a non-pregnant social drinker, what relevance did this have to me? Unknowingly, by sharing the implications of his research with me, that bright young researcher was forever to change my life. He handed me a copy of a book about fetal alcohol syndrome, FAS, The Broken Cord by Michael Doris. Half-heartedly, I agreed to look at it and return it the next week. On the plane ride back to North Carolina and in my free time the next few days, I didn't put the book down, reading it cover to cover without a break, in airport lines, grocery stores, and on my lunch break at work. I even read in the car at stoplights, the early 90s version of texting while driving. Closing the book with tears in my eyes, I understood that my life had changed forever. The way had opened for my life's purpose. Having been raised by my paternal grandmother, who only had a 6th grade education, I'd always felt that we are here for a very important purpose. She always told me, "There's nothing you can't do if you put your mind to it. And keep on with your education. It's the one thing no one can ever take away from you." Realizing I'd found my calling, I knew I needed more education to make a difference about this problem. Still traveling and working for BW&Co., I began a master's degree in health policy and administration from the University of North Carolina School of Public Health. There, my research focused on the link between fetal alcohol effect, FAE, and juvenile crime, implications for health and public policy. Children and adolescents that do not have all the facial features of fetal alcohol syndrome are less likely to be identified and receive services for their cognitive and neurodevelopmental challenges, leading to school failure, social problems, and delinquency. Networking with North Carolina agency directors and policymakers led me to a researcher at UNC's Bowles Center for Alcohol Study, Dr. Kathy Sulik. Her elegant experiments in pregnant mice since 1981 demonstrated that the effects of prenatal alcohol exposure occur before most women suspect they are pregnant. Having been runner-up for Miss Minnesota in 1968, Dr. Sulik is beautiful, poised, educated, and articulate. She is an artist as well, painting lifelike images of horses, people, and animals. As a young teratologist, a scientist who studies birth defects, she saw photographs of children with FAS at a Research Society on Alcoholism conference and was inspired to better understand the mechanisms leading to the complex array of symptoms. To that end, Dr. Sulik designed a series of experiments in pregnant mice, capturing her results in breathtaking detail using microscopic images. She had created all of the features of the full-blown fetal alcohol syndrome, FAS, with the equivalent of 4 to 5 servings of alcohol, exquisitely timed to coincide with the 3rd week after human conception. When 2 small doses of ethanol were administered to pregnant mice during the gastrulation stage of embryogenesis, the embryos developed craniofacial malformations closely resembling those seen in the human fetal alcohol syndrome. Striking histological changes appeared in the developing brain, neuroectoderm, within 24 hours of exposure. Decreased development of the neural plate and its derivatives apparently accounts for the craniofacial malformations. The critical exposure period is equivalent to the 3rd week in human pregnancy. When she presented at the next Research Society on Alcoholism conference, hardly anyone believed her results. She later confided to me that most of the men in the room scoffed, saying, "No woman could drink so much to raise their blood alcohol level so high." My own audiences over the years have tended to be criminologists, attorneys, and psychiatrists who counter, "Those guys haven't partied with the right women." This little-known and misunderstood fact astonished me, that major birth defects and brain damage due to alcohol can occur as early as the first 3 weeks of development. Of course, I knew that alcohol could cause damage to babies during pregnancy. But it was the epiphany after reading The Broken Cord and meeting Dr. Sulik at the University of North Carolina that fueled my passion to spread the word about this preventable tragedy. I was infuriated that my magna cum laude degree in microbiology from NC State University did not teach me the precarious extent of the problem, that a beverage so widely consumed as alcohol was harming babies babies well before most women knew they are pregnant. In my mind, having worked down the hall from Nobel laureates Gertrude Elion and George Hitchings, I feel strongly that Dr. Sulich should win the Nobel Prize in Medicine and Physiology for her work, in conjunction with Drs. Kenneth Lyons-Jones, David Smith, and Paul Lemoine. Their independent research that alcohol can have harmful effects on offspring may actually have been a rediscovery of information known in biblical times during the gin epidemic in England in the mid-1700s and in the late 1800s to early 1900s temperance movement leading up to Prohibition, discussed in a later chapter, Historical Perspectives. Part of the problem in many Native American communities, as well as other socioeconomically suppressed communities, that is, inner city populations, educationally disadvantaged, is that alcoholism, binge drinking, and alcohol abuse are both endemic and epidemic problems. Together with unintentional, unplanned, or mistimed pregnancies, alcohol abuse can lead to unfortunate outcomes for infants. A young woman may use alcohol before knowing she is pregnant, thereby unintentionally exposing her baby to alcohol, either because she is not using contraception or the pregnancy is otherwise unplanned. For many young women, they may have been told by their mothers, grandmothers, or aunts that I drank during my pregnancies and everything turned out okay. When people in a community become aware that alcohol can cause a problem for a pregnancy, they can intervene in the lives of their family members who may be using. When I learned about the devastation that prenatal alcohol exposure has caused indigenous communities, I became angry that very little seemed to be done to prevent it. Over the first few months working on my Master of Public Health and Health Policy Administration, the summer of 1993, I began to see a connection between characteristics of children with prenatal alcohol exposure and those written about in delinquency literature. During that time, I frequently visited offices of North Carolina policymakers and state agency directors while on my lunch hour. One of them, a director with the Administrative Office of Courts, told me, "You're going to find the kids with ND-PAE you're looking for in detention centers and training schools." What made me so angry was that he knew about this, yet nothing seemed to be done to stop the madness. I later gathered data from the Division of Youth Services and compiled a graph comparing adjudication rates by ethnicity with the population prevalence of what is now considered ND-PAE, Figure 9. A startling relationship emerged from the analysis. A similar percentage of children are incarcerated in each ethnic group as the percentage with effects of prenatal alcohol exposure. While visiting the Director of Juvenile Services, I was introduced to Dr. Charles Dean, a prestigious professor of criminal justice who was heavily involved in computer mapping of high crime areas. He became perhaps my closest ally and proponent of my theory that prenatal alcohol exposure was linked to violent and persistent antisocial behavior for affected individuals who witness or experience abuse. He often said that my explanation of the link between juvenile crime and prenatal alcohol exposure accounted for 40% of the variance in his computer mapping data. Eventually, we presented together at the annual American Criminology Society and American Criminal Justice Society conferences in 1996, just before I started medical school. Just after leaving Burroughs Wellcome to attend UNC full-time, I stopped for coffee and biscuit on the way to work as interim tribal health director for the Tuscarora tribe of NC. In that local diner, I picked up a local newspaper with an article about the high-profile murder of James Jordan, basketball player Michael Jordan's father, on the same rural road the summer before. One of the young co-defendants depicted in the article, Larry Demery, had facial features and behaviors strikingly similar to other individuals with ND-PAE. This became the first of many death penalty cases I have assisted with before and since medical school. After contacting Hugh Rogers, the young man's attorney, I was able to assist in Demery's referral to the Bowman Gray School of Medicine's pregnancy exposure team. There, he was diagnosed by a team of developmental specialists with fetal alcohol effect, the term used at the time to describe the neuropsychiatric and neurodevelopmental issues without the associated facial features and/or growth problems. Although evidence was presented during the sentencing phase of his trial about neurodevelopmental sequelae resulting from his mother's abuse of alcohol throughout her pregnancy, he eventually pled guilty and was given a life sentence in lieu of execution. I have detailed other cases in future chapters, choosing to share the relevant history and secondary issues related to ND-PAE without providing identifying information or gruesome details about the crimes. A rural Native American pediatrician once used the term funny-looking kid, or FLK, to describe dysmorphic, abnormal facial features of children with fetal alcohol syndrome. In a compassionate way, he explained that the crass term kept physicians from understanding that prenatal alcohol exposure, rather than genetic hereditary factors, caused the constellation of the features described by Dr. Smith and Jones in 1973. The offensive, unconscionable phrase reminded me of the off-putting language of medical paternalism in Samuel Shem's 1978 House of God. The revulsion learning about the way in which the most educated of our society, physicians, viewed children who could not help their disability set fire to my passion, first ignited by the broken cord. Disgust and contempt fueled the rocket that launched me into medical school, returning to the University of North Carolina in order to bring this issue to the public's conscience. Continuing my quest to raise awareness about this preventable epidemic during medical school, I took a course in broadcast journalism and completed a summer internship at Good Morning America, then produced a documentary dispelling myths about alcohol-related birth defects, funded by the Centers for Disease Control and Prevention with Dr. Kathleen Sulick. With a grant from the American Medical Association as a government relations scholar, in 1998 I worked as a summer intern with the National Organization on Fetal Alcohol Syndrome, the first and only American nonprofit dedicated to raising awareness and advocating for programs to prevent prenatal alcohol exposure. Later that year, I was inducted to the NOFAST Board of Trustees, a position that I held through medical school residency, fellowship, and the first few years of private practice. While NOFAST has done much to raise awareness about the harm of using alcohol during pregnancy, much is needed to increase the numbers of childbearing age individuals about the risk of alcohol use and unprotected sex. Since psychiatrists see both women with alcohol and substance use problems as well as individuals with ND-PAE, I chose residency in psychiatry and fellowship training in child-adolescent psychiatry. While at Georgetown University and Children's National Medical Center, I served as member-in-training trustee on the American Psychiatric Association, co-authoring an action paper urging the APA Assembly to consider including ND-PAE, that is, dysmorphic and non-dysmorphic fetal alcohol spectrum disorder, NDSM-4-TR, and future editions. I also worked under the mentorship of Dr. Paula Lockhart of the Kennedy Krieger Institute's Fetal Alcohol Spectrum Disorder Program and went on to design a similar clinic at CNMC for evaluation and treatment of children prenatally exposed to alcohol from adoptive families, foster care, and the inner city of Washington, D.C. For the past several years of private practice, I have focused my efforts on diagnosis and treatment of this preventable disorder, receiving referrals through the National Organization on Fetal Alcohol Syndrome, other agencies, and word of mouth from parents of patients. These clinical experiences have shaped my perspective of how to help individuals with ND-PAE using a neurodevelopmental model rather than the standard psychiatric care. I'm not alone in my interest to help these children. In addition to countless researchers and scientists who have dedicated their careers to unraveling the neurobiology of prenatal alcohol exposure, Government-funded clinicians across the country have studied and worked with children, adolescents, and adults with ND-PAE to better understand how to diagnose and treat their condition. Recently, the Substance Abuse and Mental Health Services Administration published a compendium of this research in a book entitled Treatment Improvement Protocol 58, Addressing Fetal Alcohol Spectrum Disorders. This publication provides a prevention and intervention guide for behavioral health and program administrators to develop and implement services specific to the needs of individuals with ND-PAE. The issues presented in the comprehensive manual include addressing unique treatment needs of individuals with prenatal alcohol exposure, as well as helping assist women in treatment to avoid alcohol if pregnant or may become pregnant. In order for us to solve the problem of exposures prior to pregnancy recognition, we must begin to help all childbearing age women and men recognize their responsibility to prevent unplanned pregnancies while using alcohol. Child psychiatrists, pediatricians, psychologists, social workers, occupational therapists, and speech pathologists are among the professionals who care for children and adolescents with neurodevelopmental disorders. Those with significant disruptive behaviors, mood dysregulation, and social communication issues often are seen by child psychiatrists for medication evaluations. As a whole, the field of child and adolescent psychiatry is woefully understaffed and underfunded, with the field being in the category of physician manpower shortage area since the 1970s. Even if every child and teen who needed treatment were to seek services, those services would only be available in certain cities and locations in the country. There are certain states with very few board-certified child psychiatrists practicing, and of those, long waiting lists for appointments. Needless to say, if the children with ND-PAE had a psychiatrist who understood their condition, they would be in much better shape than those who fall through the cracks in the system and are left with a variety of misdiagnosed labels that never help their prognosis nor treat their underlying neurodevelopmental condition. With fewer than 8,500 child psychiatrists in the United States and over 75 million children and adolescents, 1 in 5, needing services for a range of psychiatric and mental health conditions, a severe manpower shortage has existed since the 1970s. The long hours of training, 4 years of adult psychiatry residency plus 2 additional years of child and adolescent psychiatry, postponed repayment of hundreds of thousands of dollars in loans accumulated during a total of 8 years of college and medical school. In my case, I was responsible for my own educational expenses, coming from a family that was unable to support my higher education. After a 2-year stint at the United States Merchant Marine Academy, I was fortunate to attend undergraduate, graduate, and medical school at the state schools that are supplemented by appropriations from the North Carolina legislature. An honors program scholarship and Pell Grants during college lowered my requirements for loans at North Carolina State University. As a North Carolina resident, I was also able to utilize a very special loan program through a nonprofit organization, College Foundation, INC, that offers subsidized and unsubsidized loans to residents of the state. I also worked in a research lab at the National Institute of Environmental Health Sciences in Research Triangle Park to help offset my living and educational expenses. My job at Burroughs Wellcome Company helped me pay off undergraduate loans during the first 4.5 years out of college. Through public health school, I worked part-time on health services research projects and writing grants for nonprofits. During medical school, I was fortunate to receive a UNC Board of Governors scholarship, as well as a number of grant programs and scholarships to support my continued public health policy. These programs, supplemented by loans and part-time job, I incurred less debt than many other medical students putting themselves through school, owing around $70,000 from graduate and medical school. Many students are not so fortunate and end up with as much debt as a home mortgage by the end of medical school. One young child psychiatric fellow I met while in Capitol Hill for Childhood Mental Health Awareness Day and his child psychiatrist's wife owe a total of $450,000 between them. Like them, loan repayment is a hardship for most young child psychiatrists starting out straight from fellowship training. Currently, the additional 2 years of training precludes child psychiatrists from qualifying for the National Health Service Corps loan repayment program, only available within 2 years after their residency, a time in which child psychiatrists are completing fellowship training. The additional expertise paradoxically make us ineligible for loan forgiveness. With the public health background, I might have joined the NHSC and worked for Indian Health Service in order to access the loan repayment program had it been an option. Lack of assistance for loan repayment means that a majority of child psychiatrists practice in urban and suburban areas using a fee-for-service model. Although we're among the most highly educated in society, our average individual income of $183,637 is well below the median income for subspecialty training. Figure 5. The income disparity, despite the same amount of loans, leads to a higher distribution of child psychiatrists in densely populated areas where child psychiatrists are valued and reimbursement rates are high. Medicaid and insurance companies pay a fraction of the amount that FFS providers are able to make in private practice. Manpower shortage and scarcity of child psychiatrists contribute to misdiagnosis and inappropriate treatment of ND-PAE. Child and adult psychiatrists see these kids every day of the week in their busy practice settings, but often are unable to take the time to adequately screen them. Many child psychiatrists are forced to see patients 10 to 15-minute increments, often being unable to adequately assess their issues. Instead of having the time to appropriately assess the person's developmental and prenatal history thoroughly, they are left to focus their attention on symptoms and to medicate behaviors rather than looking for the underlying etiology of their condition. Knowledge about ND-PAE, appropriate supports for their limitations, and building vocational programming around their strengths allows them to live beyond their diagnosis, much like living with a chronic medical condition. By giving their parents an understanding of how to support their challenges and provide a nurturing environment to develop their areas of strength, the child has a chance to overcome some of the obstacles they face at birth and during early childhood. My approach is outlined in the appendices, and they will be further described in a companion clinical guidebook for mental health professionals to be published at a later date. My belief is that we must direct our efforts upstream to help the children when they are still young enough to benefit from the interventions and supports. Over the past several years in private practice in a home office setting, I have evaluated, treated, and cared for more than 100 patients with ND-PAE. Their capacity for understanding, judging risk, controlling impulses, appreciating nuances, navigating social situations, communicating effectively, managing a household, and other aspects of human life are more challenging than their typically developing counterparts in our modern, highly intellectualized and technical American society. Many of these individuals came early enough ages to change the trajectory of their mental health prognosis and life course. Like my mentors at Georgetown Children's National Medical Center and Johns Hopkins University taught me, I help patients and their parents understand their neurodevelopmental potential. The most luminary among child psychiatrists who have helped me understand these children, Dr. Paula Lockhart of the Kennedy Krieger Institute, taught me her strengths-based model, the capitalizes on the child's interests and abilities while scaffolding areas of relative weakness. Clinical forensic research and advocacy efforts on prenatal alcohol exposure has led me to consult on several death penalty cases in North Carolina, Virginia, Tennessee, and Georgia. My forensic work is limited to individuals with documented moderate to heavy maternal alcohol use during pregnancy. Their neuronal hardwiring predisposes them to fight or flight reactions, precipitating violent behaviors, particularly when they have witnessed or experienced abuse as children. Prior to and during medical school, I assisted counsel for Robbie Locklear, a Native American young man convicted in the murder of his Caucasian stepfather. The jury did not understand the neuroscience presented during the sentencing phase of the trial and recommended the death penalty. His case is detailed in Bonnie Buxton's eloquent memoir of her journey raising an adoptive daughter with ND-PAE, Damaged Angels. Over the years, I have served as an expert in several capital murder cases in North Carolina, Virginia, Georgia, Pennsylvania, and Tennessee, involving defendants with significant neurodevelopmental deficits resulting from prenatal alcohol exposure. Although the Maryland death penalty was repealed a few years ago, and I was never consulted on any of the 5 men who were on capital murder charges in the state, I have evaluated a variety of young people in detention centers and residential treatment programs with histories of moderate to heavy prenatal alcohol exposure. Some of these unfortunate individuals have well-intentioned adoptive parents or biological mothers who are now in recovery from substance abuse, yet have little knowledge about the impact of prenatal alcohol use on their child's brain development. Somehow, no one in the system of care treating their child felt compelled to share the important information with the parents. These experiences reinforce the findings from my master's thesis that undiagnosed effects of prenatal alcohol exposure put children who witness or experience abuse at high risk of violent and persistent juvenile delinquency. Sadly, not enough effort is spent educating parents and caregivers about the need to provide cocooning, protect from harsh parenting strategies, and assist youngsters in developing a moral compass as well as vocational skills at an early age. Having just returned from the American Psychiatric Association, APA, in Toronto, Canada, I have hope that our profession is finally at a place where change is on the horizon. There, I chaired a symposium on ND-PAE as a silent epidemic of preventable mental illness. A more senior colleague and Distinguished Life Fellow commented during the question-and-answer session that it was one of the most illuminating talks of the entire conference, yet held on the last day with few attendees still present to hear it. Notwithstanding his frustration, I believe the way will open for future presentations on a larger scale, similar to sessions I presented with colleagues at the American Academy of Child and Adolescent Psychiatry. Such a paradigm shift will surely help enlighten mental health professionals about prenatal alcohol exposure as a source of acquired brain damage that can be treated, though more easily prevented. There is hope in a tipping point presented in the next chapter, Doctors' Responsibility to Prevent ND-PAE, to prevent neurodevelopmental disorders associated with prenatal alcohol exposure, comparable to mainstream practice for prevention of prenatal exposure to other drugs and medications.